I'd like to welcome all of you for today's program BUS Stone and Conclave. I will take the opportunity to address all of you, and we will get the good time today to discuss on different topics of stone disease, starting from RIRS, PCNL, and also laparoscopic or retroperitoneal surgery. And at the end of this program, there's today's main attractions resident program, residents clinical symposium. There will be two case discussion. So without wasting any further time, as we are already going short of time, I would like to welcome Dr. Sunirmal Chowdhury, Secretary, Bengal Medical Society, to address the. First I would like to invite Professor Molloy Bera, President BUS, to address the gathering.
Respected senior teachers, friends and juniors, I welcome you to take active participation in this CME program of Stone Conclave, where we shall discuss the upper tract, primarily the upper tract stones, its management and other panel discussions. So I welcome, please Dr. Sunirmal Chowdhury, please come. He will address the second welcome address, and also will accept the chairman. He will ask the chairman to sit here.
Good evening, everyone. As you know that from Bengal Medical Society, we are organizing theme-based program. We are trying to organize it every month. This time we are organizing it on stone, renal stone disease. And Barun Saha from RG Stone Clinic has accepted to organize this program. I invite Professor Dilip Karmakar sir to be chairperson in our program. So our program will be divided in a theme-based. Like first we will go in RIRS, then prone PCL, then supine PCL, ultimately retroperitoneal. And ultimately there will be a symposium. All the residents from all the medical colleges will participate in this program. So I invite you all. So without delaying, I call on Dr. Barun Shah to please come and start the program. Okay. Okay. I request all the presenters to restrict their time limit.
Thank you, Sunirmal. Sir, Professor Karmakar sir, please have your seat as a chairperson. Okay. So I will like to first welcome Dr. Puskar Shyam Chowdhury, who will speak upon tips and tricks in RIRS. Dr. Puskar Shyam Chowdhury is a consultant urologist in Fortis Hospital. He is also the professor and head in the Department of Urology, KPC Medical College. Puskar, the stage is yours.
Thank you, Barun. Thank you, Bhaskon, for this opportunity. Let us presentation to me. Videos. So, thank you, seniors, for being present in this conclave. We will discuss about RIRS, the tips and tricks. All of you must be doing RIRS or have seen RIRS or referring patients for RIRS. Now, RIRS actually has overtaken the other modalities like PCNL and ESWL, and in most of the setups, ESWL, the number of ESWL has significantly come down with the advent of RIRS and with the improvement in expertise in RIRS. But there are certain tips and tricks with experience which we have gained. I would like to share it with my juniors, so who wants to do RIRS or will embark into RIRS. So the advantages why RIRS has taken over the other modalities. It requires minimal radiation. Often you can do it completely without using the CM. Minimal or no bleeding, minimal or no pain. Most of the time there is it's a minimally invasive, so no puncture, nothing, so pain is minimal. Can be used in patients on anticoagulants. In low dose aspirin, you can go ahead with an RIRS if you do it carefully. Bilateral stone removal can be done in the same sitting without any significant adversities. Can be done as a daycare procedure as well in a pre-stented case. And blood transfusion requirement is extremely rare. Now there are some special situations where RIRS is our savior, like post-PCNL residual stone. Often we remove it as a daycare procedure with RIRS, a small stone. You can avoid multiple punctures in case of PCNL if you have that in your armamentarium. Post ESWL failure cases, you can take out the stones with RIRS. In pregnancy, you can do RIRS avoiding radiation. In renal failure, RIRS, single functional kidney RIRS is the treatment of choice. Ectopic kidneys, often PCNL is not possible, ESWL is not possible, but you can easily access a pelvic kidney or a retroverted kidney with an RIRS. Pediatric nephrolithiasis can be dealt with, multiple stones, horseshoe kidneys, kyphoscoliosis in particular, patient on anticoagulants, and diverticular stones is one of the main indication for RIRS. So, we will discuss on the tips and tricks regarding the flexiscope related, patient related, laser related, guide wires, access sheath and accessories, and irrigation. So this is the basic how we do an RIRS. Always it's preferred to get an RGP done before starting RIRS, and it should be, you should introduce your scope or sheath over a guide wire always. And in Shyam control, you can see the movement of the flexiscope, and in this way you can reach each of the calyces and remove the stones with the help of laser, holmium laser or thulium fiber laser. So the advantage is you can check all the calyces, and the chances of residual stones is minimal with RIRS. So the ureteroscope related things, first is care, because it's a delicate instrument, costly instrument, but if you handle it with care, you can really bring down the cost of RIRS. So you should know your flexi tip design. There are two types. It might be a conventional scope or a digital scope where the camera is on the tip. So in the scope, there are two most vulnerable parts. One part is the junction of the shaft with the handle, and the other is the curvature part with the main shaft. So main problem occurs when you twist or you bend too much the junction of the shaft with the handle. So you should be very careful while handling the instrument, and you should try to keep it as straight as possible when you are using the flexiscope. You should avoid bending them whenever you are sterilizing it, as well as when you are keeping in a tray. So you should use a large table or a large tray to keep your flexiscope. So keep flexible ureteroscope straight. The junction of the body and shaft is the most vulnerable. Junction of the flexible tip and shaft is the second most vulnerable part. So you should avoid kinking that or overstretching that, and particularly when inside a sheath, you should not try to bend your flexiscope. You should ensure that your sheath is below the point of curvature, that is at least 5-6 centimeter below the tip. Always insert the laser fiber and the accessories in a straight position, because if you when the flexiscope is bent, if you try to introduce your laser fiber, it might make a hole in the seal within the flexiscope, and that hole might make it difficult to reintroduce the laser fibers in subsequent uses, as well as it can damage the water seal, and it might your sterilant or the water may enter into the flexiscope and it might damage the flexiscope. Never do flexion or extension beyond resistance. So you should not be overzealous and try to bend the lever with excessive stress, because that is the part which gets most commonly damaged. And always pass flexi over the guide wire into the pelvic calyceal system. So these are the two types of scopes which are available. Now the conventional scopes, the digital scopes used to be little bigger in diameter compared to the conventional scopes, but now the tips are comparable. 7.5 French shaft scopes are available now, we regularly use it, and the P7 has a outer diameter of 7.9 French. So do not use flexion and extension while the distal junction of flexiscope is inside the access shield. Laser fiber should not be too close to the flexiscope and it should not be too far away as well, because if it protrudes a significant length, then controlling the fiber becomes difficult, and only if you can see the tip of the fiber, that is sufficient, because whenever you are seeing the tip, that is at least 1 to 2 millimeter beyond the tip of the scope. So it doesn't damage the scope, but you should always fire when you see the tip. Use lesser energy in the beginning, less than 10 watt. So most of your stones can be pulverized or fragmented with an energy of 10 watt only. So you have to be patient. You should not keep on increasing the wattage, because that damages the laser fiber as well as it can damage your machine and the flexiscope. Avoid high energy and 200 micron laser fibers together in the acute inferior calycial calculus, because here the fiber gets significantly bent, and if high energy is generated, often it might break and that will damage your scope permanently. And you should generally avoid using larger fibers like 360 or 550 micron fibers in doing RIRS, because if in straight stones like in the upper calyx or in a middle calyx which is easily accessible, you can still go away, you can use higher energies, but if you try to pick up some fragment migrates into the lower calyx and you try to bend it, then while firing suddenly the fiber might break, because they are not as malleable as the 200 micron fibers, and that will damage your scope. Avoid pushing the stone with the flexiscope, which generally have a natural tendency to push it with the scope into one of the calyces. Try to avoid, because that damages your tip. As soon as case is over, rinse the flexiscope with saline immediately. This is very important, because one of the dreaded complications of RIRS is sepsis or infection. So you should be very careful in cleaning your scopes. Do not keep flexiscope more than the recommended time during chemical sterilization, because that makes your shaft and the malleable parts stiff. Air drying is mandatory at the end of cleaning. If you own one, you will definitely do it. Even if you don't own, you should ask your hospital persons to air dry them, because that increases the life of the scope. Now, patient related, prime important is consent. You should discuss everything prior to doing the RIRS or taking a patient for RIRS. Residual fragments, chances of not being able to negotiate inside, converting in case you are not able to access, the chances of injury, chances of bleeding, chances of abandoning the procedure. Even if you see purulent urine, you have to abandon. So everything should be explained and kept written, because RIRS often the expectation is very high and it can't be met always. You can't guarantee that you will clear the stone. So for beginners, they shouldn't do RIRS in extremes of ages, because pediatric or very elderly patients, it becomes difficult. Female patients are easier because they have a shorter urethra. Single small stones should be taken up, less hard stones, so that you don't have to lace for a longer time. Upper and middle calycial stones should be preferred rather than taking up lower calycial stones, and normal PCS anatomy. You have hugely dilated kidney, it becomes difficult to do RIRS. PUJ obstruction, it becomes a very tortuous ureter, RIRS becomes difficult. And preoperative CT IVU or IVP is very useful, but might be deceptive sometimes. You might miss a diverticular calculus even with a CT scan, but they generally help you in planning your surgery. So this is one case which we did recently. This is showing us CT scan where we can see a middle calycial stone, very obvious. And when we went inside, we found that these are multiple calculus, not a single calyx, and we couldn't find the stone. So we did an RGP and we found that it was a diverticular calculus. So now laser related, holmium versus thulium fiber laser. Thulium fiber laser is actually picking up. Dusting is much better with thulium fiber laser, and the fibers are also more malleable than the holmium ones. And it's faster because of the higher energy transmitted, it makes faster. I think gradually thulium fiber laser will take up or the place of holmium lasers. Use 200 micron to have a good water flow. Don't use larger microns in a bit to do a faster surgery. High frequency, low energy is preferred for large stones. Low frequency, low energy for small stones. High frequency and high energy is a very bad combination for RIRS. So never exceed more than 20 watts. Don't push laser fiber into the substance of the stone and activate, because then often there is a retropulsion, not retropulsion, the beam gets reflected and you damage your blast shield, and it's also costly. Don't thread the laser fiber in a tight cap. This is also another important thing where you can save on your fibers. So pushing a fiber on a tight cap may damage your tip. Now irrigation and accessories related. Choose proper lengths and sizes of sheaths for male and female. For a female, the 35 centimeter is the sheath of choice, and for male, 45 centimeter generally suffices. Pre-stenting is preferable and mandatory in case of narrow ureters while doing primary RIRS. If you are unable to negotiate, don't force, because that will cause more trauma to the ureter and it might be very difficult to manage that scenario. It's better to stent and come out and do it at a second stenting. You should mention everything in the consent. Use access sheath of smaller size. Always prefer smaller size. Even if in a pre-stented case, prefer a smaller size, because your target should be dusting rather than fragmenting. Bringing out fragments through the sheath is not a great idea, because that damages the inner lining of the sheath as well. So a 9.5 French sheath is the ideal for irrigation pump at a fixed pressure should be avoided. You should not keep on pumping you should have a 50 cc irrigation syringe is manually is very helpful. Avoid spending more than 1 hour in the PCS on one side. If access sheath is not in place, avoid pushing fluid in high pressure for better vision. So this is the sheath, and for primary cases you should always prefer a new or at least a newer one, because that the hydrophilic coating is still present and it helps in negotiating. These are the two armamentarium or which you really require. The larger one is the Encircle 2.2. This is for larger stones. You should use this only to pick up and replace the stones in other calyces. Try to avoid taking out stones from the kidney through the ureter or as well as in the sheath. And the N-gauge should be used for smaller stones to be picked up. To make RIRS most cost effective, you should choose the right size stone, proper location like upper and middle calyceal stones, hardness of stones, softer stones do yield well. Multiple stones, expertise of the surgeon. With expertise, the scope lasts longer. Then you have to consider this also in which setup you are working, because accordingly you have to plan your RIRS, whether it's a single setting, multiple setting you can afford or not. And to reduce the cost, these are available for hire also, you can opt for them. So this is for the juniors, that the maneuver, actually there are 3 maneuvers. One is going forward and backward. You see my head like this and this. So it is done with the left hand, and with the right hand you have 2 maneuvers, that is shifting like your head on the right and left, as well as with the lever you make it up and down. So minimal use of lever, try to do the maximum movements with your turning of your wrist and the shoulder only. So this is the case which I showed, the CT scan. So here you can see there is a small diverticule on the other side. We couldn't see any stone while doing the RIRS. And only this much of the laser fiber is sufficient if it comes out. That will not damage your scope. The more you extend, the more chances of it dangling and precise job you can't do. In these cases where you need a precise incision, you should ask the anesthetist to hold the respiration for the time being, and you should just cut the mucosa, keep on dilating, see whether there is any deeper structures you can see or not, and then gradually you can increase the hole and open up the diverticulum. So once you have entered, you should confirm that whether you are in the right place or not. And here we can see there are multiple secondary calculus inside. And here we are using a thulium fiber laser. We are using the dusting mode. And in this way, you can see there is minimal retropulsion with the thulium fiber laser. So we prefer thulium fiber over. So that's all. Thank you all.
Thank you, Puskar, for your excellent demonstration, particularly for those who are going to purchase flexible uteroscope, how to take care of it. Sir, question answer will be at the later end of the presentations.